Hello and welcome back everyone. So continuing our discussion about the pediatric medicine, in this video we will talk about the bacterial tracheitis. Now bacterial tracheitis, which is also known as membranous laryngotracheobronchitis or bacterial croup, is an acute bacterial infection of the trachea that is potentially life-threatening. So it affects the trachea and it often follows a viral respiratory infection, which is especially croup. So after the patient experiences a croup, they might develop bacterial tracheitis. So it is considered a bacterial complication of a viral disease. Now bacterial tracheitis is uncommon and can present as either a primary or secondary infection, but mostly it's secondary to croup, and the mean age of presentation is between 5 and 7 years with slight male predominance, and it is more common than epiglottitis in vaccinated children. Now bacterial tracheitis is caused by Staphylococcus aureus or Streptococcus pneumonia, Streptococcus pyogenes, or beta-lactamase producing gram-negative organisms such as Haemophilus influenza and Moraxella catarrhalis. Now anaerobic organisms can also be the cause. Now let's talk about the clinical features. So the classic presentation is a child with a croup, and remember, croup present with barking cough and low-grade fever, and they are generally non-toxic looking children, and they may have inspiratory stridor. So after a few days of them infected with the croup, they show improvement, but then suddenly develops high-grade fever and toxicity with respiratory distress. So they would have tachypnea, retractions, and use of accessory muscles. And they also would have stridor, sore throat, and cough, productive of thick sputum. Now in bacterial tracheitis, the patient can lie flat and does not drawl and doesn't have dysphagia, and those are symptoms associated with epiglottitis. So these symptoms are not present in bacterial tracheitis, they are only present in epiglottitis. Now with this disease, there is mucosal swelling at the level of the cricoid cartilage, and this is complicated by copious, thick, purulent secretions causing pseudomembranes. So a very big difference in bacterial tracheitis compared to the croup. The child will be producing a good amount of a thick, purulent sputum. Now let's talk about the diagnosis. So the diagnosis is clinical. The patient will have high-grade fever, which is opposite to the low-grade fever that comes with the croup. They also would have purulent airway secretions and absence of classic findings of epiglottitis. And the purulent material is seen below the vocal cords during intubation, and blood and purulent material cultures should be taken. And lateral neck x-rays may show subglottic narrowing of the trachea with irregular densities and ragged and indistinct borders, and it may also show pseudomembrane detachment in the trachea. So as you can see in this picture here, it's a lateral neck x-ray showing a pseudomembrane detaching from the mucosa of the trachea, and a bronchoscopy used to confirm the diagnosis if it's still in doubt. Now let's talk about the treatment. So nebulized epinephrine, which is very effective in croup, is not effective in bacterial tracheitis. So if the patient doesn't respond to the normal croup treatment of nebulized epinephrine and corticosteroids, then you have to put in your mind that the patient may have bacterial tracheitis. Now, intubation is required in 50% of patients with this disease, and younger patients are more likely to need intubation. And suctioning of purulent materials causes temporary relief but doesn't sufficiently prevent the need for intubation. So suctioning leads to dramatic improvement, but it is for a short period of time. Also, you have to provide oxygen to the patient and you administer empirical antibiotics, and this is ampicillin, sulbactam, 50 milligrams per kilogram per dose intravenous, or ceftriaxone, 50 milligrams per kilogram per dose, plus clindamycin, 10 milligrams per kilogram per dose. And in areas with increasing Staphylococcus aureus resistance, you consider adding vancomycin, 10 milligram per kilogram per dose. And of course, all of these antibiotics are given intravenously. Finally, let's talk about the prognosis. So prognosis is excellent. Patient become afebrile within 2 days of empirical antibiotic therapy, and extubation is done when mucosal edema and purulent secretions are decreased. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support more, you can by joining the channel by hitting the join button near the subscribe button down, or by following the link in the description of this video. Thank you for watching and peace.